An important part of fertility testing is knowing your anatomy. You have got to know that the uterine cavity is ready for a baby if you are trying to conceive. But do you know that there's different tests and different ways to figure out the uterine cavity? Today, you're going to learn all about each test and find out which one is right for you. I'm Dr. Lora Shahine. I'm a double board certified OBGYN and reproductive endocrinologist helping people build families and test their fertility for almost 20 years, and I love educating. If this is the first time that you found this YouTube channel, welcome. I'm here to teach you all about your reproductive health. You'll find lots of information here on fertility, IVF, early pregnancy. I really love educating. If you want to stay in touch and really keep up to date with what's going on in fertility, subscribe to my newsletter. I'll put a link in the description below. Every Friday, you'll get an update on fertility news, links to my most recent educational content, and then information on books that I love and products that I recommend. So be sure and subscribe to that newsletter. Today, we're going to learn all about the uterine cavity evaluation options and testing. It is essential to know that your anatomy is okay if you are struggling to conceive and you're trying to figure out why. Testing anatomy is a really important part of the initial fertility evaluation. Just like checking a semen analysis, just like checking on your egg supply, you've got to know that the uterine cavity is nice and normal, the fallopian tubes are open, and it's just an essential piece. However, there are 3 different ways that the uterine cavity and sort of uterine anatomy can be checked on, and we're going to go over each one. So the 4 main topics we're going to go over today. Number 1, we're going to go over the different options for uterine cavity evaluation to describe each one. Number 2, we're going to go over the pros and cons for each one. Each test is unique and different, and they're really good at some things and not so good at other things. Topic number 3, I'm going to share the data on accuracy for the testing. Not every test is perfect, and you should understand. And topic number 4, we're going to briefly go over next steps if you do find something abnormal or wrong with the testing that you're doing. Now stick around to the end of this video where I'm going to go over top 3 questions you should ask your doctor when trying to decide which test is right for you. Topic number 1, the different tests for uterine cavity evaluation. There are 3 options. Let's start with the HSG, or the hysterosalpingogram. Hysterosalpingogram is a long word which means HSG. Hystero stands for uterus, S salpingo, tube, gram, study. So uterine tube study, hysterosalpingogram, or we just say HSG. HSG is a very common initial fertility test because it is a way to not only make sure the inside of the uterine cavity is nice and normal, but it makes sure that the fallopian tubes are open. This test requires specialized equipment. It's often done in a radiology department, or in my practice at Pacific Northwest Fertility in Seattle, we have this special equipment in our practice so we can do this test for our own patients. This test requires basically a pelvic exam. So you place the speculum in the vagina, you have a little tube that goes into the cervix, and through that tube, we're putting in liquid. We call it dye. It's actually clear, but it's just called dye because with fluoroscopy, this is the special equipment, you're taking images, like X-ray images of the uterine cavity and area as you're watching the dye go into the uterine cavity and spill out through the fallopian tubes. This is the only way, other than surgery or looking inside the abdomen and pelvis, this is the only way without surgery to make sure the fallopian tubes are open. And a bonus is you can also get the contour of the inside of the uterine cavity. That is an HSG. Now, I have other videos here and some short form content on what to expect with the HSG, so go there to learn more. If your doctor has recommended it for you, it's really important to know what to expect, and I really hope that that information is helpful. The second option is the saline infusion sonogram, or SIS. Some people will call this a saline infusion ultrasound or a saline infusion sonogram. Ultrasonography with saline. So people will say it in different ways. In my practice, we say SIS, saline infusion sonogram, and it basically requires an ultrasound at the same time as putting sterile salt water or saline into the uterine cavity and looking at the uterine cavity with an ultrasound. So it too requires a pelvic exam with a speculum in the vagina, a little tube that goes into the cervix. And then while we're doing a vaginal ultrasound, we're instilling about a tablespoon or two of salt water to expand the uterine cavity and look at it with an ultrasound. So this does not require the specialized equipment as a hysterosalpingogram. It does not have radiation, but it does require someone that has skill in doing this test. It does require ultrasound guidance, and it is something that we too offer in our clinic. The third test for uterine cavity evaluation is the gold standard. It's a hysteroscopy. A hysteroscopy is looking inside the uterine cavity. So instead of a screening test like the HSG, looking at the shape and contour, or the saline infusion sonogram, distending the cavity and looking at the shape, the doctor is looking inside the uterus. So that's what I mean by gold standard. You know, sometimes on a hysterosalpingogram, you can see a filling defect, same thing on a saline sonogram, but you aren't really sure what it is. You know, is it a polyp? Is it a fibroid? Is it adhesions? You're not sure until you look inside. And so a hysteroscopy is taking a little camera. Again, it requires a pelvic exam, so a speculum in the vagina and then a little camera through the cervix, and you're looking inside the uterine cavity. The way I describe it to my patients is imagine that the uterus is like a balloon, and the tip of the balloon where you are blowing up air is like the cervix. And the hysteroscopy is placing a camera through that little tip of the balloon, through the cervix, and looking inside the balloon. So you're able to see inside. And we do use water, usually saline, to distend the uterine cavity so that we can look inside. All three of those things I just described is putting liquid inside the uterine cavity in order to see better. And I want you to understand why. The uterus sits in the body like this. It's got two walls and inside is a cavity, but it's not sitting there open, you know, it is two walls kind of stuck together. So sometimes people say, oh, well, can't I just do a regular ultrasound and like see if there's anything going on in the uterine cavity? Sometimes you'll see large things like large fibroids or large polyps or get a suspicion. But unless you open up the uterine cavity and really take a look inside, you can absolutely miss small polyps or adhesions or something like that. And so every test that I just described is using liquid to distend the cavity to get an excellent visualization. So imagine if I have a little marble, like a little polyp in my little uterus here. And you can look from this side and maybe look from this side, but unless you open up that uterine cavity, you won't be able to see that marble. And so it's just nice to kind of understand the concept, why regular ultrasounds without distending the uterine cavity can miss subtle filling defects and issues that might impact fertility. If you're curious what it looks like inside a uterus or what a hysteroscopy is like, I've got a great short form content here on YouTube Shorts. I put it on TikTok as well, where it actually shows me going into the uterine cavity, and that might be helpful. Topic number 2, the pros and cons of each of these tests. So let's take it one test at a time. So with a hysterosalpingogram, there are pros and there are cons. There are basically 4 pros that I talk to my patients about, 4 reasons that HSG is a great idea. Number 1, it's a tubal evaluation. So it's the only way, again, without looking inside the body with a laparoscopy, it's the only way to test and see if the fallopian tubes are open, because you're actually putting fluid through the fallopian tubes and watching in real time as that's happening, and the doctor that's doing the test is taking pictures. Pro number 2, it's an excellent way to see some subtle findings like adhesions. Sometimes, and studies differ in the predictability of the test for adhesions, but most people feel that an HSG is a better view for adhesions than the saline sonogram. Now, of course, the gold standard is a hysteroscopy, but if you're looking for uterine adhesions, and typically the sort of teaching that I got and what a lot of doctors will share with each other is that HSG is better for adhesions compared to the saline sonogram, but studies differ. Pro number 3 is that it's typically a first fertility evaluation. It's a baseline kind of way to get a view of the overall anatomy in combination with a regular pelvic ultrasound. So with the hysterosalpingogram, you get not only the information about the fallopian tubes, but you also get the inside of the uterine cavity. But that's it. That's all you get. You don't see ovaries with an HSG. You don't see the outside shape of the uterus. So when you're doing an initial fertility evaluation, you'll often get a regular pelvic ultrasound as well as an HSG. And in combining these two tests, you've got a really good picture of female anatomy. The ultrasound shows you the outside shape of the uterus. It shows you the ovaries. And the HSG shows you the inside of the uterus as well as the status of the fallopian tubes. Pro number 4 for an HSG is there are some studies that show that you are more fertile for about 3 or 4 months after doing an HSG. Now, I did do a short form content on this and happy to show it to you here where I have a reference to the study. I don't use HSG as a fertility treatment. The theory is that it's sort of unblocking the tubes if there's any sort of mucus or debris in the tubes, that just the flushing of the tubes makes people more fertile. Again, it's not hard and fast and proven, but when people are nervous about doing the study, I kind of can often share this information with people, and it's just a little bit of a positive spin on the HSG, but nothing to like hang your hat on. And then there's cons of the HSG, of course. So I can think of 4. Number 1, you are not getting a full picture of anatomy. So I talked about this just a second ago, but with the HSG, you're getting the inside of the uterine cavity and the fallopian tubes, but you're not seeing ovaries and the outside shape of the uterus. So it's great for something, but you do need more than just an HSG to get your overall anatomic picture. Con number 2, you can absolutely miss subtle filling defects. Sometimes it's really easy to see that whether the fallopian tubes are open or not, but sometimes the angle of the uterus, you can't get a full picture of the entire cavity. It depends on the anatomy, where the uterus is in the body, the technique that the doctor is using, the imaging quality. So there are just sometimes subtle things that the HSG can miss as far as uterine cavity evaluation. On number 3, it requires specialized equipment. It requires, this fluoroscopy, which is like a C-arm, and it's often only found in radiology departments or specialized fertility clinics like mine, Pacific Northwest Fertility in Seattle. We have our own HSG machine, and we can do it for our patients and sometimes as referrals for referring providers as a way to help people get this information. Con number 4, it does require radiation. That is fluoroscopy. It's like quick X-ray images in order to see this fluid go through the fallopian tubes inside your body. It is less radiation than flying on a long flight to and from a beautiful destination, but it is still radiation. It is not something that harms, eggs or your ability to even conceive. There are a lot of people that do conceive in the same month as their HSG. That's why we try to time it before ovulation when you're scheduling it. But it is radiation, and it's important to be transparent about that with patients. And so that's how we are getting the images. So the second test, the saline infusion sonogram, pros are it has less specialized equipment compared to the HSG, which requires a C-arm and fluoroscopy, or a hysteroscopy that requires, the camera and the ability to visualize what's going on inside the uterus. A saline sonogram just requires a transvaginal ultrasound, a speculum, a little tube that allows the saline to get into the uterine cavity. And so it's in a lot of clinics. It's easily accessible. It just requires training from the person who is doing it and making sure that you're getting excellent images, but it is less specialized equipment. So it's often easier for people to access this test. So pro number 2, by easier access, I mean that a lot of times people can do it in clinic, and it's easier to schedule because there's more availability. You're not trying to schedule with the specialized equipment. Pro number 3, no radiation. Again, I'm not worried about fluoroscopy as a one-time thing when you're trying to get information about fallopian tubes, but some people just feel better about trying to do a uterine cavity evaluation without it. And I think the biggest pro of saline sonogram is you get an overall picture of the pelvic anatomy with one test. So with the saline sonogram and the ultrasound, you are at the same time seeing the inside of the uterine cavity as well as the outside shape of the uterus. So this is an excellent test if someone has fibroids and the fibroids are in the wall of the uterus. You can see how much of the fibroid gets into the uterine cavity. You can see it in relationship to the uterine cavity. You can miss fibroids if you're just looking inside the uterine cavity with a hysteroscopy, or if you're just doing an HSG. Whereas with the saline sonogram, you're getting an overall picture. You can also peek at the ovaries at the same time and doing an antral follicle count. You get such a wider view and kind of feeling of the overall pelvic anatomy. The only downside is that you don't get information about the fallopian tubes. There are some saline sonogram type clinic tests where they'll try to put bubbles through the fallopian tubes looking with an ultrasound. It's not, in my experience, as easy to interpret or diagnose tubal issues as with an HSG, but these kind of bubble tests are sometimes helpful. But honestly, if you're doing a saline sonogram and you're putting liquid into the uterine cavity, at the end of the test, if you can see, beforehand it wasn't there, and after putting fluid into the uterine cavity, if there's fluid on the outside of the uterus, like behind the uterus or kind of over by the fallopian tubes, at least one fallopian tube is open. So that is really helpful if you're trying to minimize the number of tests that people are doing and you're just trying to make sure at least one fallopian tube is open. That's a little bit of a trick. Does that make sense? So again, when you start the test before you put in any saline, if you look around in the pelvic cavity and there's no free fluid, and then you do your test and you're putting liquid into the uterine cavity, and then all of a sudden you see free fluid behind the uterus by the ovaries, it came from somewhere. It came from the uterine cavity and spilled through a fallopian tube. So just a little bit of a kind of a nice piece of information if people are trying to, thinking about access to care, lower cost of treatment. It's a way to make sure at least one fallopian tube is open. The cons of the saline sonogram is you really don't get tubal information. I mean, I know I kind of just gave you this sort of like little trick for getting a little bit of information, but there could be subtle tubal issues that you might not be able to see. And of course, it's not as gold standard as a hysteroscopy, so there could be subtle things with the uterine cavity that you also might miss. And the final test, hysteroscopy, remember that is taking a camera and looking inside the uterus. So the big pro is that is the gold standard. That is like, if you really want to make sure the uterine cavity is perfect, you got to look at it. So a saline sonogram sometimes can miss subtle little micro polyps. Hysterosalpingogram or HSG can sometimes miss subtle adhesions. But if you're looking for kind of big picture filling defects, polyps, big, fibroids, you will find that on the screening tests. So a hysterosalpingogram and the HSG are screening tests, but the hysteroscopy, camera inside, looking inside, that is your gold standard to make sure the uterine cavity is perfect. Another big pro of a hysteroscopy is you can treat any issues that you find at the same time. Now, this depends. There are some clinics that do a diagnostic hysteroscopy with a little tiny scope just in the clinic without any sedation or anything. They just kind of look inside and look at the cavity. And if they find something, well, then they have to set up an additional operative hysteroscopy at a later time in an operating room. If we're doing a hysteroscopy in my clinic, it's in the procedure room, the patient is asleep. If we find anything, we can treat it at the same time. So the patient has kind of one intervention, we diagnose and treat at the same time. But it does require sedation. It requires, scheduling. So we'll very often do a screening test like an HSG or a saline sonogram and only move to the hysteroscopy if we are suspicious of something being there. But in general, a pro can be that you can diagnose and treat at the same time. Cons of the hysteroscopy is you're only looking at the uterine cavity. That is all you are seeing, and it's the gold standard, but you are not looking at the outside shape of the uterus. You're going to miss fibroids that are on the outside of the uterine cavity. They might be on the wall of the uterus or sitting on top of the uterus. But again, imagine that balloon and you're going through the little cervix or the part of the balloon that allows you to inflate it. And you're just looking inside. Imagine the camera here. This is all you're seeing. So it could be fibroids out here or here. You won't see them. You get no information about fallopian tubes. You get no information about ovaries. So amazing for the uterine cavity, but tells you nothing else about the rest of anatomy. And just a con is really specialized equipment, requires a doctor that has had training. Typically, we do it under sedation, so people are totally asleep and comfortable. And so it does require more planning, more scheduling, and more specialized equipment. So topic number 3, how good are these tests at trying to find what they're looking for? Because no test is perfect. And there are absolutely times where people have been told, I have blocked fallopian tubes. My HSG showed that my tubes are blocked. And then they find out later that actually one or even both of their fallopian tubes are open. Sometimes people will find what looks like a filling defect or a polyp on a saline sonogram, and then they schedule the hysteroscopy and there's nothing there. So there are some times where there's false positives, like the test is abnormal, but then everything's fine. And there's sometimes where there are false negatives, where it looks like everything's normal, but actually there's something going on. So no test is perfect. We do the best with what we have, but it's nice to kind of go over the data and how accurate these tests really are. I'm going to be quoting some information from an excellent review article from Fertility and Sterility. I will link it in the description below so you can find it yourself. But when I'm talking about data, I'm sharing percentages. It's either directly from that review or from some of the references that are in that review. So that's a great place to look if you want solid information or even more details about this. So as far as the accuracy of results, it depends on what you're looking for. So if you are trying to diagnose tubal disease and you're doing a hysterosalpingogram, it is not perfect. And one study showed that 25 to 30% of the time, if a tube was said to be blocked and not open on the hysterosalpingogram, when someone had a follow-up study, which is a laparoscopy, so a camera in the belly button and looking in the pelvis, 25 to 30% of the time that tube was actually open. So as this is especially true with something called proximal tubal obstruction. So, the tubes come off the uterus. Proximal means the tubes seem to be blocked at that junction, like where the tube is coming out of the uterus. Distal tubal obstruction is when it's blocked out here, and we're just not seeing that fluid is spilling from that tube. Proximal tubal obstruction is much more common, and it can be from either debris or from tubal spasm. So sometimes the uterus just contracts and it will just not let fluid kind of go into the tube. So sometimes people will get the diagnosis that their tubes are blocked and they'll just repeat it a month later, and actually they'll find that they were really open, or they'll do the laparoscopy and really get that information. So it's just important to realize that no test is perfect. It's what we have, and it's our straightforward way to get information. So certainly if the HSG shows that the fallopian tubes are open, that's much more reliable to think like, well, it's got to be open to kind of get fluid through. There's a wonderful review article that says that the HSG test has a 65% sensitivity. So that means that if there's a blocked tube, it's going to really show that it's blocked on the test, and an 83% specificity, that if it says that the tubes are open, that is really true. So it's not 100%, and that's really important to realize. What about the accuracy if you're looking for uterine cavity issues, polyps, fibroids, adhesions. Well, you should know that overall, about 16% of people that are struggling with infertility will have uterine cavity issues. So it should be an important part of your evaluation. There's one study that's noted in this review article that I shared with you that a saline infusion sonogram was as accurate as hysteroscopy, which is considered the gold standard, that if there was an issue there, it found it 100% of the time. That's pretty amazing. I will say I've been doing this for 20 years, and there are times where people have a normal finding of the uterine cavity looks normal on saline sonogram. Maybe there's an issue, maybe someone's having spotting, maybe someone had a negative pregnancy test when an embryo transfer, and we do a hysteroscopy to really evaluate, and we'll find little micro polyps, we'll find little subtle adhesions. So it's amazing that that study said that it's 100% sensitive and accurate, but that seems a little bit too good to be true. And it's just important to talk to your doctor about your situation. Another interesting piece is this review article said that the hysterosalpingogram is as accurate at diagnosing uterine adhesions as the saline infusion sonogram. That's different from my sort of general teaching and sort of talk amongst the physicians in the field. We typically like to use an HSG to really evaluate adhesions, but I think it's quite interesting that a study has been done to really compare them head to head, and they were actually equivalent. If you're looking for Mullerian anomalies, so this is irregular shape of the uterine cavity that you're born with, uterine septum, bicornuate uterus, uterine didelphys. There's many different uterine anomalies. The tests that we've talked about are not perfect in and of themselves. So in order to see a whole uterine anomaly and really get an accurate picture of the pelvis and all the anatomy, you can't isolate and just use a hysterosalpingogram because you're going to miss the outside shape of the uterus. You can't just do a saline infusion sonogram, although with 3D ultrasound added to the saline infusion sonogram, that's an excellent test for uterine anomalies. And again, a hysteroscopy where you're just looking inside, again, you don't get the overall shape of the uterine cavity. So if you're really looking for uterine anomalies, or you're having a suspicion of that and you're talking to your doctor about it, your doctor is probably going to recommend a pelvic MRI or a 3D saline infusion sonogram to really evaluate that most accurately for you. So topic number 4, what do you do if the testing is abnormal? This absolutely depends on your personal situation. Remember, the hysterosalpingogram and the saline infusion sonogram and the hysteroscopy all have pros and cons and exactly what they're looking for. So in general, if you have an abnormal finding on a uterine cavity, a filling defect on your hysterosalpingogram or your saline infusion sonogram, most likely the next step is a hysteroscopy to really diagnose it. And if there's a polyp there, treat it at the same time. If you're really looking at tubal issues, say you have blocked fallopian tubes, say you have something called a hydrosalpinx, where it looks like there's a dilated, swollen fallopian tube and it's blocked, it does not drain, that can really impact your chances of getting pregnant and success with an embryo transfer. And so if there's real tubal issues, the next step might be a laparoscopy, where the doctor can take a camera through the belly button, look inside, really see, are there adhesions surrounding the fallopian tubes? Is that a hydrosalpinx? What is happening to cause blockage? Or they might look inside and actually do something called chromotubation, where while they're looking from the top and looking through the belly button into the uterine cavity, the doctor will put saline or dye up through the cervix and watch it spill through the fallopian tubes. So if you say, oh my gosh, I've been told that I have bilateral blocked tubes on my HSG, one option is just to go straight to IVF. I mean, that's a way to treat and bypass fallopian tubes, but these HSGs are not always 100% accurate. And so your doctor might talk to you about really confirming that diagnosis and doing that laparoscopy with the fluid flush or chromotubation. And so the next steps is really dependent on your situation and an in-depth personalized discussion with your doctor. Glad you stuck around to the end, because I want to give you these 3 very important questions to ask your doctor when you are trying to decide together what the best evaluation for your uterine cavity and kind of female anatomy would be. Here are the questions. Number one, which test do you recommend and why? Like, what are you looking for? What are you expecting to find? Which test is right for my personal situation and why? Okay. Question number two, have the doctor describe what it's going to be like for you. Whatever test they recommend, have them walk it through, because every clinic is different. Every setting is different. If they're referring you somewhere, you should get information about what it's going to be like. For example, when we do hysteroscopy at Pacific Northwest Fertility in Seattle, we offer nitrous gas. So it's like getting laughing gas at the dentist. Most of the time, patients are just offered Motrin. For a lot of people do it and they say, oh, it's really crampy. But it's okay, it's over. For some people, the hysteroscopy can be really painful. And I'm so proud of the fact that we offer an additional pain control. It's optional. You don't have to use it, but it's available to you. And so that is really important. People should know what to expect and whatever test. These are invasive tests. I mean, they're putting a speculum into the vagina, a little tube into the cervix. Like, you should understand what is going to happen and what sedation or pain control is going to be offered to you and what options are available to you. Question number three, how are you going to get results? Are you going to get results right then and there? When patients do hysteroscopy and saline sonograms, all tests, we talk to patients about the results right then. We often will say, hey, I'm going to review this with your primary doctor, but this is what I saw today, and we'll make sure and follow up with you in the next couple of days. But we try to give immediate results because we know you want this information. And bonus question, it's a little bit advanced, but I think it's really important to ask, like, okay, if I do this test, am I ever going to have to repeat it? So most of the time, people only do one hysteroscopy during their fertility treatment. But if someone's doing treatments and embryo transfers, they pause that are coming back, the standard in our clinic is to do some sort of uterine cavity evaluation every 6 months. So if someone is, maybe they freeze embryos and then they take a break and they're coming back and their initial evaluation showed a normal uterine cavity, but now it's been over 6 months and they're getting ready to do an embryo transfer, we'd like to do a saline sonogram at a minimum, because things can change. And that's just sort of our ballpark, like, hey, every 6 months as you're trying to conceive, you should have a uterine cavity evaluation. That is a general recommendation for my clinic. Talk to your doctor about what's right for you. But I think that's nice to kind of get that information, like, hey, once we do this, am I going to need to repeat it? I hope you learned something today. I really hope that this information is valuable to you. I love educating. Look in the description for links to studies and things that I talked about today. Be sure and subscribe to my newsletter to get updated weekly information. Like this video if you learned something. Comment with questions that you have. Subscribe to this channel so you get my weekly video on all about reproductive health. And as always, until next week, wishing you love, luck, and pineapples.